Now, you have those elements set, and of course, there are several pitfalls that you might encounter as you're scanning to prevent you to acquiring the data appropriately. Now, if the patient has mild aortic stenosis or very severe aortic stenosis, those cases are more straightforward because the data is obvious and will always be consistent throughout the study. The more difficult patients are the ones in the middle, the moderate range, the ones that are often referred to as low flow, low gradient aortic stenosis, or the really low flow. So the elements that you need to make sure you went over as you acquired the data is, did you look at all the windows that the patient can get scanned on for specifically aortic stenosis? I'm talking about suprasternal notch, and I'm also talking about right parasternal. Were your LVOT diameter measurement done at the right time in the cardiac cycle? Some studies are done mid-systolic, others are done at the beginning or at the end. That will change some of your data, especially as you're looking at previous studies. The third element is the alignment of your continuous wave Doppler with the flow. And we all know through the cosine of the angle Doppler equation that we need to be within about 15 degree or so of the flow going across the aortic valve. If we're above that, then obviously we will underestimate the peak velocity. So the alignment is critical. Have you used the pencil probe as an additional set of data in the windows where you got the highest velocities? And finally, is it possible that there is a technology gap in the system that you're using in data processing that prevents you from actually getting the real highest velocities? And that's the point that I want to make here.